we are. Okay.
All good. We're just going to give it a few minutes just to let everybody come in, and we'll just have a bit of a chat. Fantastic. We can see some people coming in, which is absolutely great. Welcome, everybody. We'll just give it sort of maybe 15, 20 seconds more just to let people come through, and then we'll get started with some introductions and then have a chat, which would be great. Okay, fantastic. Let's get started, shall we? And then obviously everybody coming in can join in whenever they get involved. So, hello and welcome, everybody. My name's Nathan, and I'm from the European Pain Federation. And today I'm joined by several speakers, couple of speakers so far, who are here to discuss a really, really interesting topic about the biopsychosocial risk models, evidence and early intervention for the prevention of chronic pain. And also the principles of pain treatment, which we'll hopefully cover as well, which will be really, really interesting. We'll give the speakers a chance just to introduce themselves in a moment. Just to let you all know, this is a recorded Q&A session, which means that we have the really good privilege of being able to take questions from attendees. So if anybody has questions, please feel free to put them in. You can drop them in the question section, which is at the bottom of the video feed right now. There should be a section which says Q&A. You should be able to type your questions in there. I think you can also do it anonymously as well. So feel free to take the opportunity to do that if you need to. Again, just to reiterate, this is a really great opportunity to ask questions directly to the speakers. So get involved and we'll try and get through all the questions for within the hour session that we have. There's also a chat area for general discussion, so please post comments in there as well with regards to what we might talk about, or if you have any comments that isn't necessarily a question. I would also encourage questions between speakers as well. Paul and Monica, who we have here, if you have any questions for each other, then feel free to ask them. It's a great opportunity, and that will obviously facilitate some really interesting points that we can cover. And again, I think there's going to be some really interesting discussion today, which is great, especially if we get everybody involved. So again, attendees, put your questions in the Q&A section. That would be fantastic. So to begin, so maybe we can let the speakers introduce themselves, perhaps give us an introduction to who you are and your background. Maybe we can start with, let's go clockwise as everybody does on these online video calls. So Paul, do you mind starting?
Thank you very much, Nathan. Yeah, so hello everybody, and it's great to be here. So I'm Paul Campbell, and I'm a senior researcher, and I work at a large foundation NHS trust, so hospital trust, but also work at Keele University. And the background relevant to this is sort of research on predominantly low back pain and chronic pain, and a lot of our work at Keele has looked at sort of prognosis and the issues around recovery for people with chronic low back pain, really. So a long-standing sort of research there. Thank you.
Amazing, amazing. And Monica, welcome.
Thank you. Thank you, Nathan. It's out? Yeah, okay. You can hear me? Okay.
We can indeed.
Yeah, I'm Monica Hasenbring. I've been a professor of medical psychology and sociology at the Ruhr University in Bochum for more than 20 years. And I'm emerita now. We did a lot of research, and now I also did it further with my former group in factors that have an impact on the transition from acute to chronic low back pain, especially, but also in other pain syndromes. And we also looked for these factors in other fields of diseases, for example, in cancer, psycho-oncology and cancer disease. But the most package of work we did in low back pain also. And we developed the avoidance endurance model of chronic pain and several treatment strategies. I'm by myself also a clinical psychologist and psychotherapist, and I always was not only engaged in research, but also in therapy with cognitive behavior therapy. So I think.
Amazing, welcome. So as you can see, we've got a real breadth of experience in the talk today. Anybody who received emails about this talk, we also have William Shaw who shall be joining us. I think he's having a few technical issues at the minute, so hopefully he'll be able to jump in a little bit later in the talk. But some fantastic speakers. So again, guys, get your questions in and feel free to ask them. So perhaps we can start off with a nice sort of broad question about your area of expertise. So again, you've kind of touched on your areas. If you want to delve into that a little bit more, then feel free to do so. A question to Paul to maybe perhaps start is, again, give us a bit more of a description of your area in relation to the session on perhaps the Academy platform that was on there. And perhaps could we share your thoughts on whether we're getting better at providing support for people from a complete biopsychosocial perspective? We know this is quite difficult. Are we getting, as clinicians, are we getting better at doing that at a clinical level? And if not, specifically to your area, what more could we be doing?
Yeah, so I mean, I didn't say in the introduction that I'm a psychologist by background, so I've got a vested interest in the psychological components related to the progression towards chronic pain from perhaps an acute pain episode. And the kind of work that I've been involved in is looking at sort of what the psychological factors are, and there are many. And a few years ago there was lots of sort of debate about which ones are the most important. Is it the fear avoidance model? Is it the pain self-efficacy? Is it to do with underlying depression or anxiety, etc., etc.? So in my particular research work, I wanted to look at that in a whole and sort of look at the relationships between different psychological factors. And part of my research has shown that many of them are really quite related. Using statistical techniques, they overlap significantly. And really sort of the key findings from some of our work at Keele was to demonstrate that a lot of these distinct psychological factors really come under the umbrella of pain-related distress or maladaptive coping or maladaptive cognitive thinking. Sort of this pain is, indicating that my back is going to break, sort of thing, that sort of thing. So we thought that was important, that we could distill sort of the array of psychological factors into sort of easily capturable domains, if you like, and that's where it comes in helpful for clinical practice. So obviously I've just covered the aspects that I've been involved in, but in answering your sort of direct question, I think there's been a huge movement towards the adoption of the consideration of psychological factors within pain, across physiotherapy, across pain management, of course. So that's largely on board, but still the predominant sort of focus, I guess, is still unimodal, and it's centered around the biological. And there's research evidence to suggest that, physiotherapists, for example, feel that it's not their domain to discuss about psychological impacts, and they feel quite uncomfortable about doing that. But a lot of our research has sort of looked at how that conversation could be explored in practice, without necessarily having to be highly trained as a psychologist to do that. If you think about the biological approach to pain and the models that are used, quite rightly, they sit right at the front, because obviously that's the main concern. But then if you think about practitioners thinking about, well, what is the impact that it has on that person? So it's not just pain, but it's the impact that it has. So it might be that that person has to come out of work. They may not feel that they can provide for their family anymore. They may not be able to interact with their friends and families as they did before. So there's lots of impact there that reaches them beyond the sort of direct pain experience into the person's psychological and social experience. And so it's just really about having that conversation about what is the impact, how is it affecting you, how does that make you feel? And that can sometimes just open many doors to explore some of the thoughts and beliefs and perceptions that a person has that then can be tackled through, psychologically informed practice, again, which doesn't necessarily need specialist in-depth psychological training. So it's moving very well. It's well adopted. It's obviously been accepted within the IASP sort of definitions of pain for some time now. But there's still a number of barriers, I think, to full adoption of taking this full perspective rather than the bio primarily, and then as an addition, a little bit of the psychological. So I think there's still movement to be had, but I'll be more than interested to hear other people's perceptions on that. And I'd be really interested to hear any of the people that have come onto this session now that have got experience of having those conversations and how that feels, just for my own interest.
Mm-hmm. Fantastic. Yeah, there you go, guys. An opportunity to get involved. Please let us know. Monica, anything to add to that? Any thoughts around that?
Yeah, I think if you summarize the possible central dimensions of psychological factors, Paul, you mentioned the general distress dimension and the cognitive responses, and also pain coping. So I think we a little forget, for example, the behavioral dimension. So as we concentrated on the avoidance, but also the endurance behavioral parts. So the concrete behavior people show when they have pain and when they feel possibly a conflict between their pain and their duties in daily life, for example. So I think this is maybe a fourth important dimension. And another dimension we also maybe forget a little are the social consequences, sensu, the operant model. So how partners, how family will respond to pain, and the impact of these responses on the pain response and on the pain behavior, for example. So I think we could think a bit more about, really central dimensions in the psychological factors that have an impact on the chronicity of pain.
Mm-hmm. Mm-hmm. And it kind of sounds like we still need to, or we still need to make more effort to try and understand what biopsychosocial means in the patient pain experience, because there's other things that these core concepts, that the social impact of pain, which clinicians perhaps aren't considering, and maybe it's because they don't have, or they feel like they don't have the capacity to be able to consider that, and it's not within their scope of practice perhaps, but it might be a little bit easier than what they think it is. Perhaps you maybe, Paul and Monica, maybe you have some tips in being able to address those barriers. You've kind of highlighted a few things that perhaps clinicians aren't doing when it comes to a full biopsychosocial approach. Do you have any tips on how they can perhaps do that?
Yeah, I mean, there's a lot of things there. I mean, it all depends on the social aspects. I've got a research interest in that, and the family effects, and the sort of social interaction and the reinforcement of pain behaviors from that. And I guess it's perception by, and I have to keep using the example of physiotherapy as the sort of where my research is focused, is that there's the perception, well, there's nothing I can do about that. But there's a couple of things there. I mean, on the social reinforcement side, the family and friends can be an ally to physiotherapist practice in terms of sort of pain self-management. So you can harness the sort of the appropriate and helpful sort of support from a family or friends environment to actually move pain management along. I think one of the key prognostic factor that we found was the question, do you think that your pain is going to last a long time? And that was the number one above all else, even above pain intensity and disability, as a prognostic factor for chronic conditions in the short term, so 6 months right up to 5 years. So it plays a significant role. And I think that question in itself opens up many doors for discussions at a psychological level. So asking somebody, and if they say yes, so well, why do you think that? And then it might signpost that they have never experienced it this bad before, and I believe that it's going to cause me physiological and biological damage if I move, and that obviously moves on to sort of fear avoidance and the work that can be around that. But it might be the wider impact of sort of, I'm letting down my family, I feel really depressed, you know, I don't feel that I can go on. Again, sort of, it's just opening up the doors for a conversation, and it doesn't necessarily mean that that conversation has to have therapy attached to it. It's just that somebody's there to listen to the wider impact of what's going on in that person's life. And I've talked to many physiotherapists over many years, and they almost all say that the patient brings more than just the pain. So they've got a story behind it. And sometimes it can just be really helpful for people to listen to that story, so people feel valued and listened about the impact, especially people that have had chronic pain for many years. It's so disheartening for them that they just, you know, they're going to be treated about the pain condition. It's all centered around that and not really about the impact. And sometimes just having that rapport can really help with other aspects of the therapeutic alliance that you've got with the patients. So.
Anything to add to that, Monica?
No, thanks. It was great.
Summarized everything very well, and the practical things that people can use in clinic. And you did mention in your talk that one question was a real strong indicator of things developing on in the future. And it's a very simple question, which again can open up so many doors, and you can take the dive down into the different elements that might be influencing someone's pain experience. Brilliant stuff. So we have a question. Is the use of PROMs the future for screening psychological risk factors in musculoskeletal pain to prevent chronicity? If that makes sense.
Yeah, I mean, we've done a lot of work at Keele about the assessment of psychological complexity. So I guess PROMs could be seen as another facet of that. And it all depends on what you want to use it for. If it's to sort of identify those with psychological complexity, then it sits potentially well with a whole range of other measures. For example, we've got the Start Back tool, the Start MSK tool at Keele. You've got the Aribo. All of them have certain sections that tap into that. So it's another useful measure, but I guess it all depends what measure it is and what you're tapping into, because what you don't want to do is fall into a trap of where you feel that you have to measure every single facet of the psychological experience of a person with pain, because essentially what you're doing is tapping into sort of central constructs. So it's better maybe to have a few reliable, useful screening measures to sort of do that and then take it from there. But that is just my opinion, and I'm not up to speed on the latest PROMs measures that are out there. So,
Monica, what's your thoughts about?
Yeah, I think it depends a little from the setting you are in. For example, whether a general physician tries to have an impression of the risk of chronicity in a patient with low back pain, then a very short screening measure seems to be a very good first, not diagnostic, but screening instrument to have an impression of possible chronicity, the risk of developing chronic pain. But for example, in Germany, we follow a stepped care model. So if you are a physiotherapist, you have a little bit more time with your patient. And there also a very short screening might be appropriate, but also a little bit more intensive questions, for example, in a talk with a patient. And maybe also one or two more reliable, as you told, Paul, questionnaires. And if you are a psychologist and used to offer psychotherapy in groups or also as a single treatment opportunity, then you should use more reliable measures of questionnaires and also of standardized interviews and also of half standardized interviews to look at the psychological factors and which are the basis of your cognitive behavioral, for example, interventions or other interventions.
And I guess to the point that we made before earlier, that some disciplines, some clinicians might not feel comfortable exploring these psychological, these social impacts, and perhaps PROMs are a good entry level for them to be able to deliver an assessment and feel confident that this is what they're receiving, and then they can take a further look into the elements that are highlighted in that screening assessment. I guess that's perhaps the role for physiotherapists or other clinicians who feel like it's not within their scope or their skill set, perhaps.
Yeah, can I just add to that, Nathan? I mean, I think, you know, not everybody that comes for pain treatment has psychological complexity. So I think the screening measure is a really helpful way of identifying those that have and those that have, that will have an impact on whether they recover or not. You know, but a lot of people don't, so they don't need to have that conversation. It's just where those people that have high psychological complexity have been shown to benefit from psychologically informed practice, or where the clinician addresses some of those aspects, they benefit from that, whereas others don't. So you don't want a uniform approach for everybody. I think it's helpful if you sort of at the initial consultation or at some point early on, you can determine through a screening measure. So if a PROMS is used in that way, as I said, there is other well-tested measures out there and specific questions that you can use to tap into that quite quickly. So that, just to add that not everybody's going to need it or benefit from it.
Mm-hmm.
Mm-hmm. Very important point. Monica, could you perhaps explain in your talk you delivered some information on graded balance. Please, could you take a little bit further of a dive into that, and perhaps if there's been any advancements in its clinical use since that was available on the platform, perhaps in the last couple of years?
Whether it's, I'm sorry?
So you mentioned in your talk about graded balance and using that as for patients. Could you just explain a little bit more about what that means?
Yeah. Can I use a little my slide, or should I?
I'm not too sure. I don't think you will have that. Apologies.
Yeah. Okay. So the graded balance, based on the concept of the avoidance endurance model, where we have seen that patients with an extensive tendency to respond to pain with fear, with extreme fear, with avoidance behavior, the classical fear avoidance path, or people with the other contrast who show high levels of endurance behavior in response to pain, and respond in their cognitions with cognitions such as a thought suppression. So we try to suppress all thoughts on pain in order to be able to continue with the daily activities in daily life. And they show in their behavior, they show endurance behavior. So they endure in their activity despite more and more increases of pain, up to a level of a pain increase, for example, from 0 to 10 of a 7 or 8, when they suddenly feel forced to interrupt this activity and to make a large pause, break. And we have seen that patients who preferable are flexible in changing between, sometimes avoid a little, taking a break, but also sometimes endure a little in the activity despite pain. And people who are able to change between these both positions have a better prognosis in their development of low back pain. And so we developed the concept of graded balance with the aim that patients with either extreme fear avoidance tendencies or extreme endurance tendencies should learn to come to a more flexible cognition and behavioral pattern in response to pain, and find the way out of the chronic pain, out of the development of chronicity, together with other medical or physiotherapy interventions. I think it's not the only thing, but it's the psychological part of the biopsychosocial treatment components. That's the overview. So,
yeah, fantastic. And Paul, any comments to that?
I don't actually. Monica's sort of beautifully described the sort of process there and all the concept. I've got nothing to add to that.
It's a fantastic description, and if anybody hasn't seen the talk, please go and see it on the EFIC Academy platform. I guess it's a question that most patients ask when they come in is, when I'm experiencing pain, what do I do? Do I continue? Do I stop? And unfortunately for clinicians, it's not a simple answer of do this or do this. It's very much a balance. For patients to fully understand that, I guess how important is it for patients to understand that? You've kind of touched on it there, Monica, that it should be the way that patients approach it. How can clinicians support that? And how can they decide when a patient should continue despite pain or stop and take a break? How can they do that?
Yeah, we compare it with the treatment of anxiety syndromes, for example. If you look at the level of pain you feel when you do a house for any kind of work, if you sit at the computer, the forward bend position, for example, and are working, or if you are in the household ironing with a standing forward position. And so in these situations, we are looking for those situations in daily life, for example, ironing, and ask our patients for the level of pain when they start. So one patient say, oh, I start with ironing, my level was, in the morning, it was 2 or 3, or 2. And and what's about your pain increase when you are you are ironing? Yeah, after 1 hour, I felt pain of 4. So what you are thinking? Oh, doesn't matter. Go on. So and so on. And when I ask how long did you use your ironing work? Oh, 3 hours, for example. Then I was ready. I had a lot to do. So, and I have a lot to do, other housework. It's waiting for me. Yeah, and what did you experience yesterday when you ironed? Yeah, when the pain increased after 3 hours, it increased to 7 or 8. So then I was forced, then nothing else was possible. I had to lie down and taking a break. But this break needed 1 or 2 hours. So, and during this long break, she wasn't able to read any good book or to do anything that she could enjoy. She was depressed, in a depressed mood, and suffered from their cognitions that this disease will never end, and so on. So, and the clinician should use this increase and try to find out when the pain increase from 2 to 3 or 3 to 4. That's the same we do in treatment of anxiety if we use sensitization techniques, not flooding or so. And in that case, I have to explain something to the patient. I have to explain the maladaptivity of the traditional and habitual pattern. So if you stop your ironing when level of 7 or 8 in pain intensity is reached, then you give up the control of your daily routine and of your pain to the pain. You give up your control. So if you use a short break of a very limited 4 to 5 minutes at maximum at a level of 4, an increase from 3 to 4, then you have the control. You can make a break, but you must not. So you have the control. That's one very important mission. And the next is, if you wait when your pain is 7 or 8 and taking a long break for 1 or 2 hours, this kind of break does not refresh. You run the risk to develop depressive thoughts. You are very exhausted, and exhaustion and depressive mood and depressive thoughts are very intertwined. And if you use a short break in the early development, then you have the chance to be refreshed a little, and perhaps also to have the chance to feel that your pain reduced from 4 to 3 or to 2. You feel not new energy and can go forward. So in many patients with acute or subacute pain, when they don't experience a long learning history of these patterns, an education seems to be enough to put their attention to these processes and to introduce balanced techniques. But in other cases, some patients have a very long learning history from their early childhood, for example. Then it's really difficult to change this pattern, and you need a single therapy, I guess, for a longer time, because patients respond to these early early breaks with a lot of anxiety and cognitions. We call them metacognitions. So, for example, if they make a break at such early time point, it's never possible to end with my household. I never will finish. And I have more and more housework tomorrow and the day after tomorrow. And so, and we can see that a lot of mindsets would come, and we call them barriers to great balance, cognitive barriers, for example. And it's quite a hard work for a psychological clinician to deal with these barriers.
It's a fantastic explanation, and I guess one of the solutions to addressing those barriers is to address that early as possible, by a good assessment and an early intervention which looks at perhaps a graded balance and really thinking about the daily habits of the person and how they can influence their pain experience based on what they do every day. Paul, any addition?
Yeah, I think Monica's covered it in depth in terms of the process and understanding what's going on. I mean, the only thing I would add to it is I think activity interruption when a person experiences pain is quite natural, and sometimes it's sometimes involuntary in terms of how we respond to it, because I've experienced musculoskeletal pain myself, and sometimes, and I used to think before I had back pain, quite bad actually. Previous to that, being a back pain researcher from a psychological background, I was sort of saying, well, it's heavily psychological, all of this. And then I got back pain, and goodness me, the pain comes first before the thought. So activity interruption through pain is sometimes natural, but I think you've got to make that distinction, as sort of Monica was sort of saying about, well, what's the thoughts behind that? Because if it is something to do with, I'm not doing any activity because I fear, or I have the perception of fear, and that's the blockage to taking part in activity, then that's different to somebody that's actually doing the activity, but then stops because of their pain. And as Monica explained, there's a whole process to understanding that, but I think that distinction needs to be made, that there might be a non-engagement with activity through a fear response rather than the actual pain itself. So I don't know if that helps, but it might.
Yeah, may I add something?
Yeah, of course.
Yeah, I think it's very important if you train with a patient to have a short break early in the phase of increase, then you have to use a very strong schedule. So you have to agree with the patient about the duration of this break. So, for example, if I make the proposition of the patient and say, oh, try to make a break of 10 minutes, for example, then we let, these are details of the therapy, then we let rate the grade of difficulty to realize such a break of 10 minutes. And most patients with a strong endurance pattern tell you that a break of 10 minutes after a half hour of ironing very early in the process, yeah, it's really difficult. From 0 to 10, it's 9. It's impossible. 10 minutes, absolutely. Then I do, and so on. So then we agree to use a break that it's acceptable. And we go back to 6 minutes, 5 minutes, so 4 minutes. And yeah, one patient say, yeah, 5 minutes, that's a difficulty and anxiety, a difficulty of 3, for example. Oh, perfect. You have to feel some difficulty or fear or anxiety making the break, but not too much. Then you wouldn't do this task, home task. And then we have to schedule the kind of break. Sitting down, having the food on the neighbor chair, and have a short drink, and take a relaxed behavioral manner. And take a clock, 4 minutes, not longer. And then you continue with the work. So the interruption, in my sense, is only problematic if the interruption is for a long time, and also will be used at a degree of pain 7 or 8 when you are exhausted, and when you give the control to the pain, give the control away. That's a problematic. But if you widen your behavioral pattern and yeah, developing a more flexible way to respond, yeah, then you have to the chance to yeah, get back your control of the pain and over the situation. So, but the schedule of activity interruption is very important, that you continue in any case with this daily routine after a short break.
And that's the thing that clinicians will need to work with patients to. Obviously, it's trial and error. These things will probably take time, I guess. Getting patients to buy into this for such a long period might be fairly difficult, but I guess once you explain the process and explain why we're doing this, that will probably be quite beneficial for patients to buy in and give it a good go, for however many sessions that might take, right? Fantastic. When we talk about psychological factors, it's been mentioned a couple of times. When we're trying to identify the significant psychological factors, perhaps prognostic factors for chronic or chronicity of pain, we try and identify them on an individual level. How important is it to identify the relationship between them, not just how prominent they are as an individual sort of factor? How important is it to, analyze and assess the relationship between them?
Yeah, I mean, I might take that one first. I kind of struggle with that one because the research that we've done kind of shows that they're all tapping into the same thing. So I don't really know how do they work together towards a person moving into chronicity is dependent on a number of factors. So we know that there's pre-pain factors that the person brings in terms of who they are and their life experiences. So almost like a diathesis stress model. So for example, if they've experienced child abuse and then they have a painful episode, then they're more likely to then have chronic pain later on. So you've got the sort of pre-factors, and it's trying to design a model that explains it. So of course you've got the fear avoidance model, which has theoretical sort of underpinnings, which is really helpful in understanding the sort of the process of how that might lead to chronicity. But what's not understood or agreed on yet is the component factors of that model, where and when they play the roles that they play. And I think that's still up for a debate. And to be kind of controversial in a way, I don't know if we really need to know that. What comes first in something that's, in the first 3 months of an acute episode? Do we really need to work out what components come first, which leads to what? Because you get incredibly mired in complex theoretical models that really, when you're looking at the output, what you want to do is to reduce the distress, help the person to apply the right cognitive strategies and coping strategies, and as Monica said, the behavioral strategies. So you're looking at, you can be very much outcome focused rather than the details of how we've arrived at that point. That's my possibly controversial viewpoint, but it just stems from the work that we've done that really shows that a lot of psychological factors are just tapping into the same thing. One thing I would mention is that there's lots of people with mental health problems and issues that experience musculoskeletal pain, and therefore they come with that. A lot of physiotherapists wouldn't be expected to deal with that. So there might be appropriate referral routes for people, for example, that are feeling suicidal. We wouldn't expect clinicians in pain management to be the appropriate people to deal with that. So you've got to make that distinction too. But that's my thinking around that, Nathan.
And just before we get Monica's thoughts on that, I will encourage people to obviously get your questions into the Q&A. Again, you can do it anonymously if you like to, so we've got a bit of time to squeeze in a few more questions, so please feel free to get those in. Monica, your thoughts on the relationship between these psychological factors and how important it is to, I guess an addition to the question might be is perhaps clinicians like to identify a primary and a secondary and like to have some sort of logistical order there. It sounds like this really isn't possible with these psychological factors. And how can we go about analyzing that relationship between them? What are your thoughts?
my thoughts are very similar to these from Paul. So I thought, can I add something? I think you fix it very good. So
yeah, and I guess it just highlights, analyzing the relationship between them, and perhaps you can identify or initially identify a couple of things, but don't stop there. They're all intertwined, and they all have a significant impact, right?
Mm-hmm.
Paul?
Yeah, I just put my hand up there. I mean, in the work that we've done, we've done sort of theoretical modeling of the pathways using different psychological factors. So it might be depression is explained by self-efficacy, which then leads to increased fear avoidance. So if you can imagine that triangle sort of thing. But what we've done is swapped all of those components around all over the place, and many different components, and you just end up with the same answer. They all contribute to an outcome. So maybe it's better to focus on the outcome rather than how people have arrived at that, because they're going to arrive at it through a variety of different reasons. And this is, I'm not an advocate of splitting things up into ever increasing complex sort of components, but what I would say is that there is variation, and I'm sure Monica can speak to this as well. There's variation in the types of people with psychological complexities, and so we might need to do some more work on that. That perhaps there are specific psychological treatment pathways that are more appropriate for specific types of people that have high psychological complexity, if that makes sense. So there might be some more work there. I mean, Monica, in your experience, and I know it's vast, and surely there's the variation in the typology of people that you have worked with.
Yes, I think it's very different. And yeah, the question, with which of the factors to start to work with, for example, could also be a matter of the wish of the patient. So if it's more important for the patient to, in single therapy, I think, to talk about their general distress at work, for example, and difficulties with the other colleagues or with the chief or so, or whether they are largely motivated to start with their responding to pain, their coping with pain. That's very different. And also the depression is a matter of question whether the increased depressive mood we may state with the back depression inventory or so, whether it's a response to the pain, which, for example, has a duration of 3 or 4 months, or of 10 years, or whether a patient have the impression that his degree of depressive mood has nothing to do, is not say nothing to do, but it's not only a response to pain, but also happened 2 years earlier as a response to a very serious life event, for example, a loss of a family member or so. So then we have to decide from the therapeutical, from the view of the therapist, but also of the motivation of the patient himself, herself.
Exactly. That's a great summary of that. And again, any comments in the Q&A or the chat, feel free to get them in before we finish. Could you go for it, Paul?
Yeah, I mean, it was just to add to that, you've got the variation in the patients, and a lot of our research has looked at sort of patients with pain and interviewed them and everything else, and some some have variation where they are resistant to the introduction of psychology as an explanation for their experience of pain. So they'll often say, well, it's not in my, what are you trying to say? I'm mentally ill, and it's not in my, it's nothing to do with that, it's to do with the pain. And it's just really about getting across a nice tip that we found really helpful, and our physiotherapists have, in the using the pain in the brain as an explanation. So pain being centered in the brain, get control theory, and how that is influenced by people's thoughts and feelings can be a really helpful way of having psychologically averse people accept that psychological components can contribute to their pain. So that was just raising that about variation, and maybe some of your clinicians on this seminar have experienced where they've tried to introduce a psychological explanation and found resistance to it. And it was just to say pain in the brain is a great way of overcoming that.
Mm-hmm. And I guess that opens the can of worms of pain education and how you deliver that, effective ways of doing that. And naturally, you're probably going to get some resistance, and it might not be from the patient. It might be in the clinician's capacity to deliver effective information. It's a whole difficult. It's not as simple as providing that narrative, but again, feel confident in providing that, and if you can, it can really help patients. Once they fully understand that concept, they can then say that they are linked, and perhaps we can move forward with the interventions for that. Interesting. Do you want to, Paul and Monica, do you want to give us an insight into any research that you've got happening right now? Perhaps it's a continuation of the stuff that was on the EFIC Academy education platform.
I mean, I can sort of, over the last few years, my research is kind of moved from back pain patients to two extremes in the population. So one of them is childhood musculoskeletal pain, and looking at the factors around that and the predictive factors. And some of our researchers looked recently at chronic widespread pain in children, because that's becoming a concern, higher prevalence, fibromyalgia in children, again, another concern. And one of our studies looked at medical records data to see what consultations children had had that are precursor factors to the development of chronic widespread pain. And interestingly, what we found was that consultations about any types of pain, be it stomach pain, throat pain, ear pain, common pain conditions in early childhood seem to be a contributing factor to the development of chronic widespread pain. And a combination of those actually increase risk quite highly. And I think there's something about perhaps interventions in educational settings about how children deal with pain, and the whole host of things around that, about how their family deal with the children who's experiencing pain, etc., etc. So that's one level of area that I'm interested in. The other one is in the extreme, which is pain in people who live with dementia. And we've done some work looking at the difficulties in the assessment and treatment of pain in particularly people living with dementia that have communication difficulties. And that also extends to people that have communication difficulties through other conditions as well. And, we've done some really nice sort of quantitative and qualitative work in that area. One particular one was a GP talking about assessing pain in people with severe dementia. And it was explained that it was almost like a veterinary examination. A lack of awareness by professionals on the good assessment measures that are already out there, so they don't use them even though they're there, and a massive gap between prevalence and prescription of analgesia between those who have dementia and those who don't. So there's lots of people with dementia with untreated pain that are going about. And the consequence of that is that it leads to increased behavioral and psychological symptoms of dementia, which then leads to a much faster progression towards being placed in formal care homes rather than residing within the community. So two spectrum, childhood and dementia now, rather than what I used to look at, which was in the middle.
Yeah, further afield, exploring. It sounds very, very interesting though. Monica, do you have any research projects on at the minute?
Yes, we have a lot of, number of projects. And we have a collaboration with the Henrik Vector and Kelly Colt in the US on the EIH, the exercise-induced hypoalgesia phenomenon. So we are more and more interested in mechanisms of that are related to fear avoidance or also endurance. And we are very interested in factors like body image, and low back pain. That's one point, and more general in the impact of health promoting factors such as acceptance or so, besides the negative risk factors. And we are interested in questions whether patients with, in the avoidance endurance model, patients with an adaptive low risk pattern would indeed show higher signs of acceptance and health promoting factors. So we know very little about this group and the real functioning of this balanced group. And one project we start with is a long-term panel of it should have a duration of several years, and we are interested in the development of the subgroups of the avoidance endurance model, especially whether patients with high levels of endurance may develop more and more over time when they do not have treatment in their spontaneous sequelae, whether they more and more develop patterns of fear avoidance. And the patients with an boisterous endurance pattern, whether they develop more and more with the chronicity of pain of distress endurance. So the long-term development of these patterns are questions of these panels.
Amazing, super interesting. Hopefully we'll be able to see some more information about everything, which would be fantastic. So we're probably going to have to end that there today. There's lots of really interesting discussion. I hope everybody has gained lots of really, really good pieces of information from there. I would like to give you maybe 30 seconds just for sort of final thoughts, if you like. Paul, would you like to give us some quick final thoughts?
Yeah, I mean, it's just obviously the audience at the EFIC Academy. I would just advocate having, don't be too tentative to explore the impact of pain at an emotional level with the people that you're working with. It's the same as you asking your friend how they are and how they're feeling. There's no difference there. It's not you're treading on boundaries where somebody's going to go and you're going to mess up their mind and they're going to commit suicide because you've tried to be a psychologist. It's not going to happen like that. Just be genuine, which I'm sure that all of you are, but don't be scared to explore that aspect. That's the only thing I would recommend.
Amazing. And Monica?
Yeah, I very much would like to encourage psychologists and psychotherapists to open their mind more and more for the problems of chronic pain patients, and don't be anxious to have contact with chronic pain patients and with the biological and physical parts of their disease, open their mind to them. So that would be great. So we have two, not enough psychotherapists, I think, not only in Germany, that are interested in the treatment of chronic pain patients.
Certainly, definitely. Well, thank you all for taking time to discuss everything we've talked about today. Thank you to obviously all the attendees for the questions and all the comments. I'd like to take a chance just to thank the speakers, Paul and Monica, for taking time today and having a chat with us and providing us with a really interesting insight into their research and their experience. As mentioned, this webinar is recorded, so everybody will be able to access the recording, and of course, all of the other ones on the EFIC Academy education platform. And you can find a link to that in the reminder for this webinar, so check your emails and have a browse of all that. So again, I want to thank you all for joining us today. Thanks, Paul. Thanks, Monica, for joining us. And I wish you all a fantastic rest of your day.
Thank you, Nathan.
Take care.
Take care. Also, goodbye.